So good afternoon, everyone. My name is John Yip. I'm the Vice President of Corporate Services for Health Quality Ontario, and you're here for Session 7, Health Services Funding Reform, or HSFR, and the F stands for fun. Apparently this session is oversubscribed. We have over 400 registered participants, so it is a very exciting topic, and I'm glad to be able to receive all of you here at HQT this year. So I'm just going to fast forward through some slides here. Good to know there are no relationships with commercial interests, so that's good news. We receive absolutely no commercial support, so good to know that as well. I do want to remind everyone to use our hashtag, HQT2014, and to tweet. Apparently we're trending extremely well today, so keep tweeting. And just before I get going here, I'm going to introduce our moderator. In fact, I don't think she needs any introduction, but she is technically, I guess, our boss. Her staff have given me instructions to read through her bio because HQO's funding is tied to it. So I am going to read her bio. No ad-libbing. So our moderator today for this session is Susan Fitzpatrick. She is the Associate Deputy Minister, Health System Delivery and Implementation, Ministry of Health and Long-Term Care. As Associate Deputy Minister, Susan is responsible for bringing together health programs in local health integration networks, community care access centers, long-term care and physician services, and creating alignment opportunities to deliver quality health services to patients. Susan also leads the implementation of the health system funding reform and health quality strategies and is working to align quality with funding. A committed member of the Ontario Public Service over the past 3 decades, she is a results-oriented leader, strategic planner, and a skilled negotiator with the capacity to engage stakeholders and build consensus across the health system and within government. So please welcome me in joining me in introducing Susan Fitzpatrick.
Thanks very much, John.
No, you're welcome.
Well, it's my pleasure today to be the moderator for this session. When I was telling my boss today that I was going to be the moderator, we were laughing because I'm usually not known for being moderate. But I will try today. We have a very good panel today, and I think the topic is very timely: health system funding reform and the delivery of high-quality care, aligning the provincial priorities for transformative change. So I think I'll just briefly introduce our 4 panel members. I have a short presentation just as a bit of background, and then we'll move into the presentations of the 4 panelists. Have a little bit of a Q&A at the end of their presentations. Our first panelist is Kathy Szabo, and she's the President and CEO of Providence Care, the leading provider of aging, mental health, and rehab care in southeastern Ontario. Our second panelist is Dr. Kevin Smith, and he's the President and CEO at St. Joe's Health System and CEO of the Niagara Health System. Our third panelist is Donna Cripps, and she's the CEO of the Hamilton Niagara Haldeman Brant Local Health Integration Network. And finally, Dr. Adelstein Brown, and Staney is the director of the Institute of Health Policy Management and Evaluation, and he's also the Dalla Lana Chair in Public Health Policy and the head of the Division of Public Health Policy. So with that, I'm going to start into my presentation. So I think the case for change is compelling. We know change is necessary. So the environment can't stay the same. And I just wanted to look at change in terms of 4 dimensions. First, the fiscal challenge. Ontario is currently spending about 42 cents of every dollar on health care. And we know if we do nothing that it could eat up to 70% of our budget within the next 12 years. The demographic challenges are huge. As people age, they use more health services. The cost of care for a senior is 3 times that of anyone else. And then the complex care, the challenge of health care for this group. We've been around talking to you about the health links that the top 5% of high users account for 2/3 of healthcare spending. But it's also interesting to note that 25% of these patients will see up to 16 different physicians in 1 year. And finally, unhealthy lifestyles. We're not as healthy as we could be. 25% of healthcare costs are due to preventable illness. Nearly half of all cancer deaths are related to tobacco use, diet, and lack of physical activity. So we know we have to make some changes. We've been working at it for the last several years, and we've managed to flatten out the trajectory of growth. And in the 3 main areas, we've seen large contributions in terms of drug reform, hospitals, and physicians. But going forward, maintaining the cost growth at 2% will require an honest conversation on structural changes to our health system. And I think it is interesting when you look at the cost trajectories, they are starting to inch up. So I think last year was just under 3%. It came in at about 2.7%. So we've really got more work to do to get the growth in line with the budget. Ontario's action plan, we've already achieved a lot. We set out a plan in Ontario's action plan and made significant progress. Investing in community capacity, we've expanded home and community care. We've improved quality with the introduction of the Excellent Care for All legislation in 2010. We're improving access to primary care with our family health teams. We're working on fairer funding with health system funding reform, quality-based procedures, and drug costs. We're supporting health promotion through our Healthy Kids strategy and Smoke-Free Ontario. We've started a major integration initiative. 67 of an expected 99 health links are up and running. And we've expanded the scope of practice for health human resources. So over the next few years, and I think 2014 will be more of the same, but it's going to need a focus. And this is the framework for strategic action that you will see us addressing when we come out and speak to you. And we have 4 areas we'll be concentrating our efforts on. The first is modernizing home and community care. We've spent a lot of time working in the hospital sector, and we know we need to now turn our attention to home and community. The second dimension is improving system integration and accessibility. We've been doing work with health links there, and there's other changes we can make in that area. Ensuring sustainability and quality. We're continuing on our quality journey with quality improvement plans and embedding quality into the sectors. And then continuing our focus on increasing the health and wellness of Ontarians. Measuring results. Measurement is important. I've put this slide in here especially for Kevin because he has tutored me over the last year that performance measurement is important. And we're going to look at our successes. So we need a sustainable session, managing within 2% growth, healthier Ontarians, more days at home, more years of healthy life, integrated care, innovative care, accessible, 100% of patients with primary care provider, high quality, improving patient satisfaction. These are indications of the measurements we would be looking at. So the QBP roadmap, we started out with acute inpatient, and I think we've made significant progress. I visited about 20 hospitals, so I know the QBP implementation is active. And now we're moving to outpatient clinics and emergency rooms. And then into transition. Can we do a better job in terms of looking at QBP between hospital and transition home? And finally, community. We've been working for about a year, I think, on what we could do to bring the quality-based procedure concept to community care. QBPs, past, present, and future. This slide, I think, is a little bit scary because it just shows the amount of activity we have. So we've started out with essentially a focus, I would say, on body systems. We've done a lot on musculoskeletal, eye, cardiovascular, and so forth. And we've defined our QBPs by diagnosed diseases with specific treatment pathways. And I think the next phase of QBP will be moving more to a patient type, and I expect our panelists may well comment on this, but broadening into a programmatic approach to prevention, detection, and continuum of care. So I think you'll see different models emerge as we move into new areas. I'm very excited that in the near-term horizon, we're going to actually get out a request for proposals, or I should say expression of interest, for integrated funding models. We're actually going to see if we can bring some funding together for better care for patients. We're modeling that expression of interest after a project at St. Joe's Health System. And it's on integrating funding between hospital, acute care, and community care. So probably in about December of this year, there will be a session where we'll ask people that are interested to come in and talk to us about what that might look like. So better system integration. We believe that integrating funding models, sometimes called as bundled payments, will help us align existing policies. And you can see, I think, a consistent theme on integration. Our health links, I think, have been an excellent example. Now we're going to move into kind of an integration of funding, bringing together Ontario's Action Plan for Healthcare, our vision for home and community, our excellent care for all legislation, our health system funding reform, and then bringing in a new dimension on integrated funding models. And one final comment, I think, on QBP and QIP alignment. We've done a lot of work over the last 3 or 4 years bringing you different quality products. And some of the feedback we've got is that they've got to be better aligned. So in terms of QIP, we're looking at cross-cutting system priorities. And these will be reflected in the QIPs as big dot indicators. And then the QBP metrics will inform the organization and unit level change. I wanted to focus a little bit on the priority of patient engagement, and perhaps our panelists today will also speak to that, because this is really a huge opportunity to do more in terms of patient engagement. I know many organizations are doing that. And it will be part of a dimension of interest for the ministry. Where to next? I'm not going to go over every segment of this, but I think there's progress to be made. Where we've been, we're still doing a lot of sector-specific work. Primary care is not well coordinated. We've got leadership focused in the acute sector. We're still organizing care around providers. We're doing incremental volume-based funding. We use siloed levers. We're disease-specific. We have separate, distinct quality focus. We're focusing on quality and cost, and one size fits all. So what can we do to strengthen the system? We need to use integrated approaches. We need to be coordinating care with all health system partners, developing leadership across all sectors, organizing care around the patient, looking at system-wide capacity planning, mutually reinforcing everything we're doing, really truly creating a patient-based or a person-based system, embedding quality in everything we do in our programs and funding, focusing on appropriateness and recognizing difference and that customized approaches may be needed. So I'm going to now turn the next session over to the panelists. And I believe the first panelist is Kathy.
Oh, do you want me to stay here?
You can, yeah. What do you like doing?
I can stay here. Okay, thank you. Wow. Thank you. Is this mic on? There we go. Thank you, Susan, for asking me to come and present with my prestigious panel members, all of whom I've worked with before in the past, and I'm so excited to be here today representing Providence Care. We are a very blessed organization in this regard. We provide rehab, complex continuing care, long-term care. We have the Manor, and we have 20 community-based programs. So we look at our organization as one that has the ability to move people across the continuum. And we work in a part of Ontario where we have 7 other hospitals that we work with in a CCAC and a LHIN that's very supportive. So it is very interesting to work in a community where 7 or 8 people can sit around a table and make some decisions and make some changes from a patient perspective. So it is very interesting how we're moving forward, and it is a burning platform. And the burning platform for us revolves around how are we going to be able to fund the services that we delivered. Mitigation and HSFR is coming off next year in our area. We have, within our organization, our complex continuing care area has a fair number of patients that have been with us for 28, 30, 22, 15, 10, 7 years, and another young gentleman who is, well, he's only been with us for 2 years, has nowhere else to go in the system, and because of an accident, and he was all set to go home, and his mom was going to take him and built a house around him, and then unfortunately his mom became very ill, and that option wasn't available. So he's 21, all he wants to do is go to university, and he will probably be with us. If we can't find somewhere else for him to live, he'll be with us for 52 years, and that's just not right. So the burning platform isn't just money, it's about the patients and the clients and the community that we provide service to, making sure that people get care where they should have care, because this young gentleman, while relatively stable, requires a lot of nursing care and physician support and physio in order for him to survive. In our organization, our history is strong. I just want to share with you that we handed out the last of our long-term service awards this week, and we have a combined years of service to just the 10, 15, 20, 25, 30, 35, 40, 45-year award winners of 3,325 years of service. So people are committed to our organization. To walk into our door, you know how much people care, not only about the people that we give care to, but about each other. And they've been there a long time. And so when you're trying to change how you think about patient care and the funding realities that are coming forward, the biggest burning platform for us is changing the culture of the way we think about our patients, what we think about our buildings, what we think about our community programs, and trying to make sure that patient flow and the goal of getting people to be as independent as possible outside our organization is first and foremost. So complex continuing care and rehab in our organization are the areas right now that we've provided a lot of attention to in the last little while. We've used research, we've used the staff, we've used the funding formula, we've used this as an opportunity for change. The one thing that I didn't tell you yet is that we are also building a brand new hospital. So occupancy should be in about 3 years. November 2017, it will be complete. We're moving in the summer of 2017. So using a new organization to move our complex continuing care patients, our rehab patients, our mental health patients together onto a new site is a way that we want to be able to touch every person in our organization to be a part of that and have them understand that in order to get to the new organization, we have to make some changes. Complex continuing care itself does require us to take a look at the patient and think about shorter lengths of stays. Look at what kind of services are required for patients to be able to go home and making sure that every patient has a care plan, much like HealthLinks. And it's not about a list of services or tests that are being ordered or the results. It's about a care plan that the patients and all of the care providers can understand and deliver on behalf of the patient. The good thing about HSFR is if we do what we should be doing in our rehab area, we'll be able to see higher patients with a higher case mix index, and that will result in us getting more funding on a per patient basis so that we can in fact balance off the complex continuing care patients that are labor intensive but not high intensity needs patients. As I said before, one of the biggest areas that we've provided some focus to in our organization is educating the frontline staff and the physicians. In the past, our organization has looked at us being the care delivery system for our patients, and now we have to look at if the patients are not 100% healed or totally independent, how do we transition them to another care provider so that we're making sure that our organization is providing the right amount of care with the right intensity to the people that actually need to get the care in our organization. Educating the frontline staff and physicians is ongoing, as well as implementing an EPR system so that our physicians and our staff can understand where everyone is, where their focus is with patient care for the patients. We also have recently implemented a slow stream rehab program, a rest and restore or assess and restore, as well as a day program for rehab, because we see our future as linking very closely with HealthLinks and our primary care physician group in our area so that people can be identified when they start to decompensate and come to our hospital setting or our institutional setting to get the kind of care that they need to go back out again and to stay home. So I'm pleased to say that last month we had 100 admissions and discharges on our rehab floor, and that had never happened in the history of Providence Care. So that meant all of our staff, physicians, professional providers, allied health professionals, support staff, and right down to the house cleaning services and facilities look at how to change over beds a lot quicker. We have moved our occupancy to 100%. I will share with you that in some of the patient rooms where the patients have been with us about 20 years or longer, they're in semi-private rooms that tend to become private because they actually live with us. And their furniture needs exceed what a typical hospital area would look like. So much so that when we had our staff picnic last year, they all came because they felt they were part of the family. So, I mean, they are part of our family. So what we've seen is a 67% decrease in length of stay, a 50% increase in discharges, not deaths or repatriations to acute, but an increase in discharges home, a 16% increase in the case mix index for the specialized rehab. Timely assessments, the EPR, and educating the staff on how to do those assessments have been key. And I think initially we underestimated the need for staff and physicians to understand exactly what our goal was, but our goal in keeping with the ministry is the right level of care in the right place at the right time. That's it. Kevin?
Thank you.
Thanks, Kathy. Great story. Let me talk to you a little bit about what we've done in bundled care at the St. Joe's Health System and the Niagara Health System. I have some thank yous, first of all. First, I have to confess I'm so old that I still call it hashtag and number sign, and I don't know how to tweet. And for a minute, I thought I heard that Staney worked for the Dalai Lama today, and I just got that straight. So with that, some real thanks before I get into our story. And the thanks go to the bookends on this panel, Susan and Donna, Susan at the ministry and Donna at the LHIN, who we worked with so closely to develop this model, and the ministry team. I see Michael Stewart and the team all here today, so thank you for that. A lot of work by a lot of people across a lot of organizations. And of course, my colleagues at St. Joe's, who the real leader of this project, Carolyn Goss, I see is here. Carolyn, wave. So afterwards, if you have any questions, the person who actually did the work is here. You can talk to her. And I think that's just tremendously important work. In addition to Carolyn, Donna Thompson, Jane Longkey, Winnie Doyle, and our physician leads. So we started a few years ago with a system that came together because a group of boards with what used to be member organizations of the St. Joe's system, which each had their own management team and their own structure. And the board said, this doesn't make a lot of sense. We're frustrated by the points of transition, particularly for our aging parents or our kids with chronic illness. So you have all of this in one enterprise. Why don't you act like it? And the board really challenged us to go away and say, since you have this structure, how might you maximize it in managing care across the continuum? And working very closely with the LHIN, the CCAC, our colleague Melody Miles, our other hospitals in the region, and then of course very closely with our home care agency and others, focused down on a number of areas that were relevant, both in terms of clinical need and where government was interested in developing funding models. So one was, pick one where you're the regional program, and that's rather academic, and that was cancer, lung cancer surgery, and pleural space surgery. Hips and knees, as you recall, 2 or 3 years ago, was the focus of the day, particularly in improving the standardization process as well as quality, outcome, and cost. So we picked those as well. And last but not least, chronic illnesses, the ones that we all talk about, know are so important but are exceedingly difficult. We landed on congestive heart failure and chronic obstructive pulmonary disease. And the teams, again led by Carolyn, then really got together and started talking about what does the process of care look like. And I'm a bit ashamed to tell you that there were Post-its literally around this space about the size of this entire room a couple of times when we looked at each individual and discrete process within the continuum of care from your primary care experience through to your home care or palliative care experience. And the team just started working very, very diligently at breaking those down. Obviously, bringing all of those providers together, community service providers, home care providers, CCAC, primary care, hospital care, required some difficult conversations. And Carolyn, again, expertly facilitated a process where we, after a lot of niceties and nice discussion, came to the reality. And the reality was that the hospital people really didn't believe that home care people could look after very sick patients, i.e. 2 or 3 days post having most of your lung removed. And the home care people thought the hospital people had a comedy of riches. No matter when we call you and what we call you for, you only have one answer: go to the emergency room. And that honest dialogue really resulted in breaking down some barriers and saying, what else could we do? So the teams then developed what else could we do in a very meaningful way. And I apologize for the size of the slide, but I'll just tell you in general, the focus, as always, this isn't rocket science, so it's client-centered. And we talk about that so much, those words are so common to us now. It was incredibly important to talk about what does client-centered mean for a lung cancer patient versus a chronic obstructive pulmonary patient. And what does that mean, for example, when a primary care physician who's making that referral wants to, for the most part in a lung cancer intervention, say, over to you, look after the patient, and when it's time to transfer them back to me, do so. While in COPD and CHF, somewhat over to you for an exacerbation, but keep me fully involved. So one of our great learnings out of this is client-centered care, one size definitely does not fit all. Tremendously important for you to talk about what that means in your patient population. Integration coordination, we've called them any number of things, but we've been experimenting with what kind of people and what kind of caseload can coordinators with what kind of background do work that allows the coordination of care across the continuum. And you won't be surprised to know that it ranges greatly, that one need not look only at a nursing model, and increasingly the cost pressures in the system for us have been to continually ask the question, is there a less expensive, competent provider who might do a piece of this work while still remaining true and honoring our collective agreements? We've also spent a lot of time in this project on the debate of standards versus standardization. Maybe versus is the wrong term, standards and standardization. And what we landed on fundamentally was standardization where appropriate, but standards always. And the importance, to Susan's earlier comment about performance metrics, of really looking without any rose-colored glass on how we're doing, including if we're doing badly or if this doesn't work, let's stop and try something different. The other areas that were very important to us were simple technology solutions. And when we started this, there was the fear, there was even a suggestion that it will require a major IT install. And because of the scars on many of our backs, we decided that would not be a successful intervention and used very, very simple IT solutions, including home care systems, which actually have worked very well and interfaced very well with the broader systems that we use. Also reminded us, surprisingly, telephones are a remarkably effective intervention if you use them appropriately. And last but not least, our biggest IT expense was actually at the suggestion of our patients and families, all of whom were intimately involved in the design, was iPads. And our first patient said, I have an iPad and you have an iPad, does the doctor have an iPad, and why do I need to drive back to Hamilton so you can charge me $25 to park? When he could see me here and I could be much more comfortable. And from that led to a really very broad application of technologies, all of which I will assure you were commended by the Privacy Commissioner. And the importance of real-time medical access in that model was dramatically different. And last but not least, don't be afraid of change in the middle of this. The other starting formula for us was third-party, completely independent evaluation. So the programs for the assessment of technologies of healthcare, better known as PATH, funded by the ministry, led this. And I couldn't reinforce firmly enough the importance, in my view, of true independent evaluation. When clinical teams come together, or even organizations, and you really want something to work, it is important to have people unblemished in terms of looking at our data and telling us, I know you'd like this to work, but the data really doesn't support it. And that's been very important and very helpful. So this next slide really just describes for you the model, and the model really is you should meet the people who are going to care for you in hospital and after being in hospital before you get there. They should know about your home needs. You should know them. You should be able to recognize them. And the fundamental importance of the care team knowing one another. And for all of you who are involved in clinical care, you'll appreciate that it's a Friday afternoon, and often a leading nurse might say to a leading thoracic surgeon, can Mr. X go home? And the question becomes, well, what will Mr. X get at home that weekend? And in this model, Mr. X, it'll be very clear what he gets and who will deliver it to him and how that support will be delivered, and if he requires a greater level of care, that Mr. X will be returning to the hospital, not via the emergency room, under no circumstances via the emergency room, but directly to the unit. And one of the challenges to the clinical team was to say, you now have this unique resource. If someone needs to come in from the community, then perhaps someone needs to go out from the unit. And again, with these very specialized home care foci, you'll be able to achieve that. And I have to say that that's worked exceptionally well. Impact, I won't spend a lot of time, the data's there for you. It's impactful. It's particularly impactful in the number of areas where the largest number of procedures are. I'm focused in this slide on lung cancer surgery, but suffice to say up to 25% savings in our most common lung procedures. To date, we've been reinvesting that in additional capacity, so doing more work. In the fiscal environment in which we find ourselves now, we may need to say, well, we'll be able to maintain our access to our community, which Donna will be expecting of me in my various agreements with the LHIN, but do so while finding some savings within the envelope. And that is obviously very important as we begin looking to the future at how we'll provide high quality, efficient, and sustainable care. The words better, faster, cheaper came to us, and I want to just share with you a really important story. When we started this and we started a dialogue with some of our PSWs, the professional group, which I want to rename community technologists, these folks were absolutely essential in helping to understand how we could do things in what I then described as a high quality, efficient, and sustainable way. And a very direct and vocal PSW said to me, I don't know what you're talking about with that language. What do you really mean? And we engaged in a discussion, and she came back and said, quite rightly, you want me to do this better, faster, and cheaper. And the answer to that was absolutely. So really now we have the team referring to the project as a better, faster, cheaper project. And that simplicity of language has actually made a tremendous difference, and we now get frontline people talking about, is there anybody who could do this piece of the work as well or better, quicker than we can, and for a less costly alternative. And that isn't without its challenges, obviously, but suffice to say, the better, faster, cheaper mix has not only resulted in almost all measures of improvement, but importantly, those that government were particularly interested in, ER return rates, you can see the data, the top graphs, very different, and obviously readmission rates. And again, I want to, Donna, give the LHIN some credit. One of the really remarkable things in this project for us was that for the first time we were able to look at all emergency room representations in the LHIN, not just your own. And you'll all know that if I was discharged from an emergency room and not happy, I might, or discharged from a hospital and not that happy, I might choose not to go back to that hospital's emergency room. In this data, we were actually for the first time able to look at all emergency room representations. And interestingly, it almost doubled the number of people who represent to emerge when you look at it at a LHIN-wide basis, which is something much broader than this discussion. Just before I turn over to Donna, I want to concentrate on people. And the importance, I think, of this project for me has been coming to understand the challenge that frontline providers are feeling, the challenge of resiliency. Most people on the front line are telling us consistently, I don't see a light at the end of the tunnel. I actually see a very challenging future with demography and demand. And when we talk to people about this model of care, we consistently heard back, I've never worked harder, but I've never enjoyed my work more. I feel that the work that I'm doing is work that actually contributes to high quality patient care. And I feel that I have enough control over my work in a small work unit that I can change how I do my work appropriately with a group of colleagues. So for us, one of the most profound and impactful conversations I had was again with a PSW who said, before I started this project, I was the lady who gave the patient a bath. Now I'm part of a team that cures lung cancer. And that was really important to me to realize just from a self-actualization perspective and what that makes a care provider feel like in terms of the work they do. And as we all know, the satisfied patient does not occur without the satisfied provider. So I think increasingly, while we hope to expand the model and we look forward to working with the ministry and the LHIN and others in doing so, I think that whole issue of how do you give employees in an environment where more and more and more appears to be demanded and is likely to continue, more resilience and more hopefulness about a future with better models of care and better quality of work life. Thank you.
Thank you, Kevin, for that. Before I go on to my presentation, it's so wonderful to work in a LHIN where you have providers like St. Joe's and Kevin's leadership who really says, let's use this idea of a bundled payment, which is really focused on money, to really make a difference to the patients, and as Kevin just mentioned, also to the staff. And so that it's really not bundled payment in ways, it's about bundled care. And there's just, to me, that's what it's all about. And I think we've heard that from both Susan and from Kathy so far. And so continuing on with what Kevin has said, and it's been a really exciting project for me. And Kevin's right, he's got a great team that's implemented just a great model of care that's making a huge difference for people in our LHIN and making a huge difference for the staff who look after them. So my presentation is going to take us a little bit different because I was asked to speak about health system funding reform from a LHIN perspective. So it's not from all LHIN's perspective. It just happens to be the Hamilton, Niagara, Haldeman, Brant perspective on this one. Certainly, health system funding reform has been dramatically different for all of us. But under Susan's leadership at the ministry and under Michael's leadership within the ministry as well, I know there has been so much hard work done to make this funding reform a success. And when I think of over the last 3 years, the number of times we've gone back and forth and tried to do things differently to make sure we don't have unintended consequences, I just can't start my presentation without saying a sincere thank you to the ministry, to the work that you have done, because it is just, I think you're tireless about that. And I know that you've engaged a lot of providers in that tireless work, and I know that they've given you really good feedback as well. And that shows to me, because when it ends up rolling out to the LHIN, then we see the work that you've done behind the scenes, and I don't know that you always get the credit that you ought to, so congratulations and thank you. So my goal, as I said, is to share with you the perspective from the LHIN. I'm going to start by just giving you some overall comments, just a couple of slides, honestly, and then looking at overall comments, looking at QBPs, and then looking at HBAM, because that's how we separated it out. When I spoke to my team about this, these are really their comments, because they're the ones that are doing it on a day-to-day basis. One of the things that the one team member said to us about a year ago, and I think it's really an important way of looking at health system funding reform, is what we're trying to do is create a less imperfect funding system that's transparent and can be explained. It's not that the system we're at today is a perfect funding system, but it's less imperfect, which is kind of exciting. We've seen a lot of changes with the providers, so my focus obviously is more on the providers than on the patients. But we've seen a big change in providers since health system funding reform has come into place. For example, now we hear them talking about how, and you're all those providers, how good data is really the most important thing. So when I think back to my days when I was working at a hospital, we'd have coders who were submitting data into the ministry. I'm not so sure as a CEO of a hospital that I was attentive enough to those coders and ensuring that that data was good. I would say to you that now the providers are really focusing on that data because they know that the data that's going in is going to impact their funding going forward, which is really an important piece. I've also found that the conversation has changed. So if you think of a business model and think of any business model, your customers are often your revenue source. If you're selling something to customers, they're your revenue source. But in healthcare, typically your customers or your patients or residents or clients are your expenses. We don't see them as the revenue. And I think what health system funding reform is making us think about is our customers, our patients, our people we serve as sources of revenue. And that's dramatically changing the conversation, which I think is a really important thing to have. Also, we know that as we all become better understanding in the formula, it will drive our behaviors. We know that. That's just human nature. That isn't negative at all. That is just the fact that we have to always be aware of unintended consequences, so that we have to be willing to be flexible and move forward. Susan mentioned that it's really important that we look at the entire person as we're looking at funding. And what we need to be sure with this funding reform is that the funding that's happening is really making a difference to the people we're serving, and not just allowing, if you will, me to be a bit crass, just not allowing providers to get more money, but rather really making a difference to the people we're serving. And that's an interesting dynamic that goes on because understandably you need to be able to have money to be able to provide the services that you're providing. But if we're doing it only because we as an organization need more money, that's probably not the right reason to do it. And I think the health system funding reform is moving us in that right way. So just looking at quality-based procedures first, when I think of what we're really trying to do, we're trying to do it in our LHIN and I think across the province, is look at how can we have the best clinical program offered at multiple sites. So the same clinical program happening throughout the LHIN. It can be throughout an organization like Kevin might describe, a renal program, a great renal program that's currently at St. Joe's, and now they're exporting that, if you will, and now it's at St. Joe's and Niagara Health System, so within kind of the umbrella of organizations. How can we have that good program at other sites within the LHIN? How can we have that good program throughout the province, in fact? And I think quality-based procedures is allowing us to do that. It's allowing, certainly for us at the LHIN, while before we had health system funding reform, before we had this kind of impetus to make a change, we'd have good conversations. People would come to the table. Yeah, they'd come to the table sometimes. They'd have good conversations. They'd leave. And we'd think there would be good action. But honestly, when it's tied to funding, it's changed the conversations. Different people come to the table, different people are more engaged, and they leave with action, and things start to change. So we are seeing that different people are coming to the table. Physicians are a huge component of quality-based procedures. They need to be engaged going forward. So here's the quality-based procedure, here's the funding that's associated with it, and how are we going to move this forward within our LHIN? And honestly, the LHIN can't do that without our physician and our clinical colleagues to move that forward. So I would say that it's really been a lever for us to change the quality of care for the patients, or maybe I should say it's beginning to be that lever. I'm not sure that we're out the other end yet, but that's an important piece. That's on the very positive side of quality-based procedures. There is a side that maybe was an unintended consequence, and certainly we are seeing it in a big way in our LHIN, and that is when you look at a length of stay that's built into the funding formula, you end up identifying ALC earlier in the trajectory than maybe you would have in other times. And so, interestingly, our ALC rate has gone up. Now, we're looking at that and trying to see, is that real? Is that coding? What is that? But that has happened. We have seen that. So it's something to be able to think about it. We have also seen in the past, hospitals had that flexibility to be able to fund something, to try something out of their global budget. And as we've been moving forward with some of the funding reforms, hospitals understandably are less able, they don't have that flexibility to try something over here because they need to be able to focus on the quality-based procedures in their HBAM. And while this hasn't happened in our LHIN, I know that there has been conversations that for the amount of money we're getting and given the quality that we must come to, we don't see that we can do that procedure anymore. And so hospitals may, in fact, choose to get out of the business. And I think we'll have to be careful of that as we go forward. Certainly, we're trying to watch that carefully so that we don't end up in a situation where we can't provide the care that we need close to home. And then just the last slide, looking at HBAM, I would say to you the first 2 years of it, and the ministry people will be no surprise here, I think a lot of people were just spent time trying to understand the formula. So if any of you have opened the HBAM formula Excel spreadsheet, like, oh my goodness, it's really complicated. I take it home, I really try to understand it, and I just can't. So I know there's people very much smarter than me that can, but it's a really complicated formula. So I think people have taken a couple of years to understand it. And I dare say that there were some people in the healthcare system, again, me being very blunt and honest with you, I think that they were saying this too shall pass, and we'll just let this happen, and we'll not worry about it because it'll pass. But I think that this government, and congratulations to them and to the ministry, they've said, no, this isn't going to pass. We have to move forward with it. And so I think that what HBAM has done is it said to us, you know, you've got a population in your Lynn area. In our case, it isn't growing. It isn't a particularly growing population. Here is the health of your population. Here is what we expect the cost of the services in your particular organization. Here's what your actual costs are. And, you know, it goes into some sort of blender and it blends all out, and here comes the numbers out the bottom. And it's really changed our conversation in a big way. I thought maybe I'd share with you the change conversation with CCAC in particular, because I thought it was really interesting. All of a sudden, CCAC, they're a great provider in our Lynn for sure, but they're starting to say, ooh, maybe we need to work more with our community support service agencies a little more to take some of those people who require PSW services, but maybe they don't need our skill set, so community support services could do that. So that's a conversation that we weren't able to have before now. And so that conversation is happening. That they're asking themselves, what can we be doing differently this year to be able to improve our efficiencies? So, for example, congregate care wasn't even addressed a year ago. Today, their efficiencies are much greater now because they're looking at congregate services. And that's because of the HBAM formula. It's made a real difference, made them really look at things differently. And they're also looking at what are others doing that we're not doing, because we have to be able to keep up to everyone else. So it's really changed that conversation. I think that the mitigation had mitigated, if you will, the impact of the HBAM, and now that mitigation corridors are going off it, I think people and the providers are really starting to feel that impact, and really it's become real. For me, this is the year where HBAM in particular has become real. And one of the pieces that I don't know that everyone fully appreciates yet is that the efficiencies that you achieve in this year and last year, you have to keep up. You have to keep up to everyone over year to be able to keep moving forward, because that's what the formula will make us do. It'll make us continually improve and to keep efficiencies going, and that's really what we meant to do. That's what's meant to happen. So that's just a quick look at the Lynn perspective on HSFR.
Great. So it's a real pleasure to be part of this panel. I'm going to do the typical academic thing here. I'm going to go through a much more complicated proof of what's already been demonstrated here. Okay. Claim that it's insight. So my job is to link some of the evidence from around the world that talks about cost and quality, and try to extrapolate from that to what we can do about funding. I'm going to put up a lot of studies. I'm not going to read out complicated slides to you, but they will be available for people who want to dig into them. So what do we really know about this idea of linking quality and cost and using funding mechanisms to actually draw that linkage? Well, like I guess all good academics, I have to do on the one hand and then on the other. On the one hand, this is a very hot area. There's lots of work going on in here, but it's not yet at that level of evidence that we use when we want to make a decision about this drug or that drug, or even that level of evidence that we use when we talk about this device or that device or particular care sort of pathways. That being said, the other thing I'd point out is that all of these sorts of studies happen kind of in real time. So no one ever stops everything and says, let's reform funding and see what happens, and then we'll start to pay attention to everything else. So they're quite, to be blunt about it, very messy pieces of work when we look at it.
I have no
But
idea.
what do we know? Well, when you look at, say, the evidence within single organizations, like within a hospital or within a clinic, you find a pretty consistent pattern. There is a relationship between cost and quality. It is largely mediated through adherence to things like guidelines, so it's nice, simple sort of approaches that if you follow what the evidence says, you'll get both an improvement in cost and an improvement in quality. And The gains, quality, are real. The improvements in cost, though, are rather small. And in some ways, I think this kind of reflects the old Peter Drucker quote that people may remember, that doing things right is efficiency, doing the right things is effectiveness. And so this little bit of evidence of what happens when you try to put evidence into care really reflects that first half. This is doing things right, and I think this is not surprisingly where a lot of funding reforms start. Where the payoff gets a lot more interesting is when you get into this idea of doing the right things. This idea of expanding the scope of funding models to include more than one sector. Of getting to that question not just of are you going through the right guideline with this patient group, but that broader definition of quality that's come up consistently throughout today of the right care at the right time, in the right place, by the right providers. And so when you get into this ability to start to substitute care in one place for another that's lower cost, to make sure that care is upstream rather than downstream where it's more expensive, then you start to get much more substantial payoffs. There's a couple things, though, that I think are really, really important about this evidence as we go through it, though, that I want to draw out. The first, and it's the stuff that is drawn out on that last slide. Integration is a critical element here to actually reducing cost and improving quality. Tight little bits of better evidence do something, really working the patient through a much better and more effective trajectory of care, much more impactful. The second is that this isn't something that can be kind of done from outside, right? Despite, I think, the power of policy and so on, this has to be adopted within organizations, and I think that's why the balance on this panel is the right one. This has to be led by people who've got the right culture in their organizations to actually drive this sort of change. And so culture, trust, leadership are critical issues. The other thing, though, is that this isn't something that gets fixed, again, just through a funding formula. In some ways, I think the weakness of the literature from a scientific perspective is one of the most fundamental insights from it as well. You need to have actually a system that's capable of improving. You need evidence of capacity. You need capacity to actually engage in improvement activities. You need care coordination. You need better funding, but you also need structures that start to reinforce what you're seeing within the funding or what you want to achieve out of the funding models. The other thing that I think is interesting, and this is a very profound sort of shift in the literature on this, is that it's not just about pay for performance or simple sorts of incentive schemes. What seems to work best is some shift of risk onto providers. And so it's this idea that the people who really know about care should be the ones managing that care, as opposed to some sort of centralized or sort of coordinated type of central management. And in the US, although there's a lot of caveats on this, and to a certain extent elsewhere as well, gain sharing, this idea that if we improve quality, we can share in the savings afterwards, seems to be a very promising and effective model. And so in the United States, there's things called accountable care organizations that look interesting. But really, even dating back to 1991 and the Medicare studies at that time, there's lots of evidence that when you actually get people empowered to manage care, and I could almost walk through the first two presentations and show why that's important here. When they're empowered to actually manage care better, they do manage care better, and both cost and quality improve. And that's reinforced by funding models that make that possible. That's reinforced by structures that make that possible. There are issues, I won't get into them. They're great topics for a long sort of scholarly discussion about principal agent challenges and so on. It does require thoughtful, careful policy at the strategic and at the operational level to make this work, but they are manageable. What I think is perhaps also sort of interesting to see is that as people get into these new models of funding, policymakers are really trying to maximize along two dimensions. So it used to be that we might try to maximize productivity, and we'd look at something like activity-based funding, or we might try to maximize around accountability and look at some types of fund-holding type models. Now I think what you see is that people are both trying to maximize integration, as much of the system coming together in organizing care around an individual as possible, and also accountability for the costs and the quality around that model. Okay, so it's less now about regionalization, In the international literature, it's much more about the organization of care around groups of patients as they go forward. And so it's a fundamental shift cognitively or from a policy perspective away from just the structure to what you actually want to achieve out of that structure, which I think is an important sort of direction. I think the other thing that people are realizing is that all these goals that we're now holding up for our system are team sports. And so even if you want to get into this idea that we're going to improve adverse events or patient safety even within hospitals, you can't do that by just dealing with the hospital, or you can't do that just by dealing with some of the hospital-based clinicians. You need to bring both of them together. And I think this is a challenge for health systems like ours and like most single-payer systems that have traditionally had very, very high walls between sectors. But as you see, as we get into more and more exciting outcomes, the idea of getting into, say, readmissions or chronic disease management or even ALC that proves remarkably resistant to change, or even to health outcomes, we have to expand our notion of the health system. And I think that's why we'll probably see over time those systems that have had a thoughtful approach to patient engagement and a thoughtful approach to caregiver engagement as well are those that are going to be most able to actually make the jump to some type of health outcomes-based funding at the end of the day, because it gets to be larger and larger and larger, and sooner or later you need to start treating your health system not as 25,000 doctors or 150,000 nurses, but actually about 13.5 million people, all of whom will be engaged in care and self-care at some point as they go along. And just a couple other things I might sort of put out. There is no one system of funding that works well. Having watched health policy for a long time, it's a great field to be in because there is a new fad and a new fashion almost every couple of years, which is great. It keeps universities in business because we're always ready to teach those new fashions. But it looks like this has to be constantly adjusted, and it also looks like there's no one-size-fits-all model within a single jurisdiction, right? So it's constantly adjusting for different parts of the system. As they come together, they don't. And I think that's going to be a constant issue in Ontario, given that we are not a uniform geography. You can go from Toronto to some of the most remote and sparsely populated places in the world in just a few hours, and you need to be able to tailor the model each time for what's going on there. I'd say that value is a vector, and one of the most bold things that I think the United States did is it didn't say we're going to look at cost and quality through readmissions and through a few things like that. They put things like patient experience into the mix. Patient experience may or may not reduce cost. I don't know the answer to that question, but it's part of a whole vector of quality that we want, that we can't sort of separate out and try to say is going to be justified because of its impact on cost. No, it's just part of the quality picture that we want to change. And then I'll also say, and this is where I think one of the big challenges remain, is that the inequalities in health still exceed inequalities in any other type of input into the system, right? And so funding models aren't going to correct the inequalities in our system that affect people every day at kind of the street level. And so there's need to actually look not just at funding, but at governance more broadly that deals with the things that drive those fundamental disparities in health. And it's probably a system and clinical governance issue as much as it is about the funding model or the structure of the system. I'll just make a couple of little points here. Obviously, the formatting has value-added my slides here, or I didn't have these on as I went along. We can't treat any of this as a field of dreams strategy. I think people have tended to sort of forget Kevin Costner, but there is that nice film about Field of Dreams in the book before it. You can't just build a policy and expect people to show up and start playing on it. And I think in each of the talks that we've had today, you've seen an evolutionary process as people have kind of changed capacity, changed roles, and even changed their perspective or worldview on what they're doing in an effort to try to get behind that. And I think one of these important things that we need to keep in mind is that we do need to prepare providers to do this. They do need support, but they also do need to feel like they are really in part of the game. And I think, Donna, you were really emphasizing that at the end, that people now sort of see that the data is important, right? Yeah. You actually do have to pay attention to this. The engagement's important. You do have to pay attention to this. I won't go through this. I think everyone's already talked to this very nicely. The final thing I will say, though, is that if you look at how funding models have and haven't worked around the world, they happen in a very different corporate context in each country. Okay, and so what the U.S. does is heavily guided not only by what their health laws are and what Obamacare looks like, but also the way that they organize companies, corporations, industries, and sectors. And that's true in any country. And so I think, we need to take a very thoughtful approach to reviewing regulations for barriers to collaborations, but it has to go past the roughly 4 acts that the Ministry of Health is responsible for. It has to look at things like the Corporations and the Charities Act for this to really work, because they're fundamental ways that shape how we organize any industry, and we tend to ignore them when we look at the health industry. The final thing I'll say, and I'm really just echoing some stuff that Kevin, I think, drove home in a very practical way. We like to look for that silver bullet. And I think, we've all heard that sort of statement that, if we just had an electronic health record, this would all work out better. Or if we just had the right funding model, or if primary care docs were in charge, or if this group was in charge, it would all work out better. And when you look at all the systems around the world that have made a successful transition from being kind of, middle of the road to doing a lot better, there's only 3 things that are common. It's not the electronic health record, it's not the funding model, it's not the structure, it's none of those things. It's a very public, specific statement of goals. And I know this sounds like one of these wonderful things that academics like to say because it is such blinding common sense, but if you don't actually say where you're trying to go, you're not going to get there. And there is a paper by someone called Fitzpatrick that makes that point in terms of health targets. If you want to see blindingly obvious scholarship, but it's important. Countries that set targets around health improvement did better than countries that didn't. And it's repeated every time you look at it. So a plan with goals is important. Public reporting of results with a clear link to improvement plans are really critical. And Susan and Kevin have made this point. Measures are important, but you have to need to pay attention to those measures. It can't just be generating data for data's sake. And that's why public reporting is effective, because it's a cheap way to make sure people pay attention. And finally, you need the engagement of the people who are going to be responsible for care in the improvement activities. This can't be imported expertise for improvement. It has to be owned at the ground level in each case, and needs to be sort of sustained there rather than just brought in and then taken away when a short-term goal is hit there. The other thing I'd say is that just about anyone here who's in healthcare, I think, got into healthcare for the right reasons, right? And so for some reason, when we get into policy discussions, we start to treat them as logical or rational economic actors rather than people, which are messy and complicated. If you don't hit a strategy that deals with quality, if you don't start with quality, if you don't deal with the things that are real improvements in patients, you'll lose any ability to appeal to the intrinsic incentives, and you'll be forced to rely on increasingly complicated economic schemes to manage people rather than appealing to the, I think, the really fundamental things. Anyways, thank you.
We're pretty well on time, so we've got about 10 minutes for questions. So if anyone wants to start it off, I could ask one to get it going, but I'm sure there's people in the room, and I see one coming up to the mic right now. I know there's one in the front row too, but go ahead, Brian.
So let me ask a question to Kevin, because Kevin's work has been touching on all of the issues that were addressed. So one of the work you're doing is incredibly exciting. You have a bit of an advantage because all of the entities are in your system. And one of the most attractive parts of bundling care or bundling reimbursement is that it elevates accountability to the collective as opposed to individuals. But one of the implications is it does, as you work for better, cheaper, faster care, it does shift away some compensation from some of the actors, some of the individuals, some of the organizations. Can you comment on either the challenges you've been facing in shifting that compensation and payment, or the kinds of challenges you imagine will occur as you move beyond a system that owns all of its parts to different corporations, different organizations?
Sure, Brian. I think my first point would be, just because you're part of one corporation doesn't mean you act like it. So I wouldn't say that being in a single incorporated entity makes Site A versus Site B versus Business C think that they're any more aligned than completely separate corporate entities. And in this model, one of the things that we needed to do in our home care division was actually subcontract in some therapy areas, depending upon the needs of patients. So we had the good fortune at the big bang picture of let's do this, of corporate entity, and I think that was really important, a board that said we're going here and we're committed to it. But after that, it could equally have been done by strategic alliance with board and executive team daily engagement. Without that, I'm sure it would have, like many other things, been a nice story. On the shifting dollars away or shifting dollars to different forms, we have had lots of discussions, and I think some of my CCAC colleagues are in the room. I hope they are. I invite them to comment on this as well. It wasn't always an easy discussion for we or the LIN or the CCAC, but the moment, as Steny was saying, we came back and said, well, could we try what's best for the patient? And could we agree if it doesn't work, we'll stop? That we really did move forward quite rapidly, and I think people were willing and able. I didn't, and I should have given both Minister Matthews and Minister Hoskins more than a little credit, because they were brave enough to say, we're going to break a few rules and let you try this. And I think with Dr. Bell as our deputy, we're in a new world order of someone who's been on the provider side and very enthusiastic about trying things, and if they don't work, then we should try something else. So I think the biggest issue, Brian, is get on the table that there might be some economic pain, and if there is, how will you mitigate it? If there's a risk of somebody potentially going out of business, that's not going to stimulate them to say, gee, I'd really like to take this model on. Let me pick on my physician colleagues in this discussion who were terrific. I actually expected in some of the areas, particularly in hips and knees, that we might hear this has actually interfered with some of the issues in our fracture clinic. And I never got a call, and they're orthopods, so I always expect to get a call, and I never got a call. And I finally called them and said, how come this is so quiet? And they said, because my day is better, I have less stress, the nurses aren't mad at me that I'm running late. I actually can schedule a couple of more things that I want to do and that might even be higher value, both clinically and economically. And to be honest, I was just grateful to have the new model of care. So at the end of the day, the solution in my mind is we need to be less cautious about having the money discussion. We often avoid it. And what we did in this one, again, I want to thank Dr. Goss, Carolyn Goss, who's with us. We put it on the table right in the middle and said, so whose ox is getting gored and how do we mitigate that?
Another question?
Yes, it's Chris Hayes from St. Michael's. This question is for Steny and Susan. I'm not sure if I'm allowed to ask you a question, but I guess I am.
Given
that the public health system covers about 70% of healthcare costs for its citizens, with the other 30% being covered mostly by group insurance or out of pocket, and those things that aren't covered are maybe arguably the things that keep us well: medications, preventative services, durable medical equipment, and psychotherapy. But they're covered by either out-of-pocket or private. Are any of these strategies, because I think that's something, it's quite different between a lot of the other countries in the way they approach their publicly funded system. Is there any strategies, either evidence to support that in Canada or strategies with the ministry to look at, is there a partnership that could occur between those that provide those non-covered services and those that provide public health spending?
The one thing I would say is, I mean, that's huge public policy, but where I have seen a lot of discussion is how can we get the various components of healthcare made available for those that need them, that can't afford it. So there's quite a bit of a focus, I would say, on low income. And is there models where we could make sure that their costs are being covered? And I think you'll see a little bit of that. I mean, there's low-income dental, some low-income drugs. So I think it's a bit of a reallocation. And I think you'll probably find our current minister kind of wading a little bit more into that. But Steny, you may want to.
Yes, I'd be perhaps a little more sort of bullish on this. You saw on that chart that as you get into more interesting outcomes, you have to include more of the system, right? And so I think there's sort of two ways of looking at this. One, the question of sort of, hey, say having drugs outside of the bundle and having the drugs outside of the way that we're managing stuff is just fundamentally flawed to my mind. And the recent studies say in the New England Journal about value-based coverage are a potent reminder of that. Or the nice data that's been presented by ISIS that shows that our mortality gradient by income status breaks at 65 for diabetes. Why? Because drugs get covered, right? It's not all of a sudden at 65 socioeconomic differences don't make any impact anymore. So I think there has to be some sort of more aggressive approach to starting to loop this in. In the short run, that probably means partnerships between docs and pharmacies and others who are trying to make sure that essential medicines get out to folks. In the long run, I think it's a little more profound. The place where I think you do see some perhaps signs of hope in some of the European jurisdictions and also in the Antipodes is the closer link between public health and primary care. That they actually are both publicly funded, but they tend to sit so remote from each other at times that we miss the opportunity for some type of solidity and strength there.
Can I just add something, Chris? And while we're looking at those as when someone actually needs treatment, I think if we are committed to transforming the healthcare system, we need to look at health promotion, not just from the bigger, broader public health lens, but as every one of us that are care providers get back to basics and keeping people well and not needing a system, have hospital as the last place you want to go, have medications the last thing you want to order, and making sure that when you do, when a physician or somebody that has a patient with multiple morbidities, that they have that right pharmacological assessment that takes a look, because we've done, in my previous position, we did some work where we looked at people with chronic disease, more than one, in the hospital more than once, over the age of 19. Every patient in that group that came home on our pharmacy program had minimum two, mostly three medication errors. They either had double medicines ordered, they were taking them at the wrong time, they were having it taken by the wrong route, and they really shouldn't have been on them all to begin with. So I think we need to get serious about getting back to basics, getting people out of bed when they're in the hospital. 1 day in the bed equals 1 month of rehab, limiting the amount of medications, and actually going back to basics and trying to get people to health.
Okay, one more question?
Thank you.
Everyone likes that response?
I'm going to be picking up a bit on what was just discussed here. It's Angie Hayden, Association of Family Health Teams of Ontario. And that's that whole discussion about if we're talking about cost savings, a lot of the research has also identified that investing in a very solid primary care system is associated with lower cost systems right across around the world. So the presentation was excellent. Thank you very much for that. It is focused on people who, once they've been diagnosed with something and are needing those higher levels of care. What my question is really about the thinking, because there's been so much thinking about how the system is funded. I'm just wondering if there is some preliminary thinking about the primary care piece. I know when we look at, see presentations about health links and so on, we always start with the patient. I mean, this is picking up what Kathy was just saying. You start with the patient, you wrap around that patient that ongoing long-term comprehensive primary care that really works at that level of recognizing the social determinants of health that person's coming to the system with. And it's that investment at that end that hopefully mitigates some of the other needs in the system. And when people do need those other things, there is that point where primary care is connected back to that. So it's wonderful to see the quality-based procedures bringing so many more of the elements together in this, and I just wondered what the thinking about how primary care might be integrated into that as well. Thank you.
One comment I would make is that primary care has had a huge investment in it. So, there is funding in the system, and it has been a priority for that, I'd say, the last 10 to 12 years. And the system we had in the early 2000s has totally changed. And I mean, some of our discussion was, how can we actually measure the performance of that system and its contribution? The second comment I would make, when we were looking at health system funding reform and quality-based procedures, we see that applying to all sectors, just as we have with QIPs. So we started in hospitals. That was, the easiest place. Now we're moving into community. But clearly we have to move into primary care. And I think some of the work that I've been seeing more recently is moving into more population-based models. So I think we will catch up with primary care. It's not kind of on the near horizon, but it's certainly something that has to be looked at. I don't know if anyone else wants to comment. Kevin?
Maybe I could make a comment in our model. I would say unquestionably the major linkage going forward clearly to build what I'll call more accountable care organizations is to better integrate primary care. The challenge, as the questioner knows and many in the audience have discussed, is how does one engage primary care? And I think there are a number of discussions. I see Paul Cooligan is here today, is very passionate about this. The OMA, I know, is very passionate about this. Are there better mechanisms of coordination, governance, data collection, opportunities to look at how primary care systems are performing, and what's in them, so that we may almost have a redefinition. As you know, in the United Kingdom, some of the most high-performing regions have seen almost a eradication of the line between primary care services and social services. And I suspect that is an important part of our transition to accountable care entities.
Great. Well, I see it's about 5 after 3, so I think there's probably something. Is there something happening, John? Is it 3:30? Yeah. 3:15, yeah.
Oh, 3:15.
So I wanted to thank the panelists. I think this was a great discussion. I've learned a lot, and I hope you have. Thank you very much.